I'm Mia Levy. I'm the Chief Medical Officer at Foundation Medicine and a practicing oncologist at Rush University Medical Center in Chicago. We're going to be having 10-minute presentations from all of our speakers. I will be kicking us off. We'll be talking about how we can do a better job of evaluating integrated diagnostics in the context of data sharing as well as in electronic health records. All right, my disclosures, most biggest one is I work for Foundation Medicine, but I will not be talking about any of that content today. So what I do want to focus on is this concept of a learning healthcare system in the context of evaluating integrated diagnostics. There's many different definitions of a learning healthcare system, but this is my sort of favorite version of such a diagram. The concept being that you take your national guidelines or the literature and you create a local implementation of this through a local clinical guideline. You then implement this in your healthcare delivery system, and ideally you're analyzing the outcomes from the data that's being generated from the regular standard of care to be able to reinform your local guidelines, inform the discovery pathways back into the national literature, as well as iteratively improve your implementation. And we've been looking at this at Rush with an eye on using this to for evidence generation in the context of cancer screening and specifically in breast cancer screening. As you all know, there's many different clinical practice guidelines for breast cancer screening, all of which start with mammograms and then add on and add on. This is a large population, typically women over the ages of 40. So it's a huge percentage of our population that's getting screened or should be getting screened every year. And we're seeing in the electronic health record the increased use of structured documentation in the mammography industry. Mammography is actually one of the most regulated spaces in imaging, but is also in diagnostics, has been for several decades already. And that regulation has resulted in an increased amount of structured documentation uptake across the whole system. It also has one of the best outcomes as far as quality, and it was interesting, no, perhaps not a CLIA standard, but screening technology has significantly well-defined outcomes for cancer detection rates and positive predictive value of biopsies that are very, very well standardized and highly adopted and can be used to evaluate new technologies. But screening studies are incredibly difficult to perform. You need very, very large populations. The diagnostics are changing very, very rapidly, and it's difficult to accrue patients to prospective studies. So it becomes an area that is really ripe for a learning healthcare system. This is just our data from our single institution. We likewise have that COVID dip in 2020 of the number of diagnostic breast imaging studies that were done, screening and diagnostic studies, over 500,000 breast imaging studies over a 14-year period of time. And you can see the growth of various modalities during that period of time. We have a very diverse patient population, as you can see, largely centering around the ages of 40 to 70. But we have less than 50% white population with a huge diversity of patients to learn from within a single system. And an increasing amount of structured data available. So starting I think Atul mentioned, like, what year did they start their EMR? So our imaging system, we can go back to 2008. We have structured BI-RADS data dating all the way back there. BI-RADS was one of the first, federally regulated documentation standards in the country. And then breast density also became a federally regulated documentation requirement to share those breast density results with women receiving breast imaging. And now we've implemented a cancer risk assessment program to go along with that. And so as our structured data has grown, so have our efforts to leverage this data to learn more and more from the experiences of every patient. So we've done what I call a reference implementation for a breast cancer risk management learning system. That's a lot of words. But as we're talking about integrated diagnostics today, just to remember that breast screening is not a moment in time. It's a longitudinal experience for women. Radiologists compare images over time. So when we talk about integrated diagnostics, it's not just one moment in time where imaging and pathology are interpreted together. It has to be over the journey of the patient. And to measure the outcomes and the impact on patients and their health really does require an understanding of that entire system of care to understand how downstream those integrated diagnostics are being used to impact patients' health. So at the local level, we implemented a new set of risk assessment guidelines using standardized, Tyrer-Cuzick and other GRAIL and NCCN risk models. From that, then developed a set of risk-based supplemental screening guidelines and how to manage that risk when it was identified. We then implemented this in our healthcare delivery system. While Epic is the majority of our EMR, we were using third-party risk calculators integrated into Epic, as well as our pathology system, which is not Epic at this time. So I think Nick was mentioning, you might have 7 systems. I think we have 250 systems at our hospital. Just to give you a sense, it's not just 7 by any means. And so with that, we implemented this risk calculator for every patient coming in for screening imaging in the breast center. We were able to report this risk back to the patient, as well as have follow-up recommendations in their individualized patient report that they receive. So getting back to how you engage the patient, breast imaging has been one of the few fields that actually sends a patient letter with language that patients can understand, with the recommendations and an interpretation of the findings. In addition, we implemented a high-risk navigator to help drive these patients towards follow-up appointments in the high-risk clinic, as well as increasing our hereditary cancer risk program. It's really important that the diagnostic journey and integrated diagnostics doesn't just stop with making an interpretation. It really needs to go all the way down to actually the action of the next steps in the management of that patient. And then finally, in the analysis component, we've been looking at the uptake of our guidelines, the differences in our population distribution of risk, as well as automated calculation of cancer detection rates directly from the electronic health record data that's collected as part of the point of care. This is including for supplemental breast imaging, not just for mammograms. This, and I loved how others have pointed out the use of order sets. So one of the reasons why this has been made possible is because we have a super order set that allows our clinicians to order breast screening as appropriate for the patient's risk, their breast density, their other features of their hereditary genetics, and they leave it to a breast imaging center to drive the next steps in that patient's diagnostic journey. As well as documentation within our cancer staging forms, as Travis was saying, is not an insignificant thing. But if we're going to say we find more early disease, you got to have stage associated with that. And then the regular documentation systems that you would have, but looking at the distinctions between population management from a work list management perspective, which is part of the workflow, versus a population analytics downstream. And the stuff on the left of the blue line is all things that are integrated into the electronic health record, whereas the things on the right are really outside. And I think Atul mentioned, Tableau analytics. Much of the analytics that we're doing in our learning systems is still outside of traditional vendor-driven systems. So you're still building a lot of this on your own. So these are the results for our initial 3 years of the program. With the patients on the far right having a personal history of breast cancer, so about 7% of our whole population. And in the blue, those patients are eligible for supplemental breast MRI according to new guidelines. That's 65% of breast cancer patients, according to the 2018 ACR guidelines, would now be eligible for supplemental breast MRI. Our next steps are to see how many of those 65% actually did receive the supplemental breast MRI, because recommending something and having uptake of of that guideline are two totally separate things and are often patient-driven and not just provider-driven. And then in the middle category, you have our patients who did the uptake of the Cancer Risk Assessment Program, of which about 10% were identified as being high risk, and then who also would be eligible for a supplemental MRI. And then those who are at average risk or declined assessment, those who had dense breasts are in the green and would have been eligible for supplemental automated breast ultrasound, and those in yellow would just receive standard mammography. And what we have found is of the greens, about 40% uptake so far for that recommendation. So still not where we would want to be. And unfortunately, fortunately for Illinois had a regulatory opportunity that supplemental screening was mandated by Illinois state law, but now CMS has actually just undone that for Medicare patients. So it's a complicated time. Uptake is highly determined based on the payer coverage. And then finally, when we look at the risk assessment, over 8,000 patients were identified as being high risk based on various risk scores such as Tyrer-Cuzick, NCCN, and GRAIL, with either follow-up for recommendation of genetic counseling, for which we have about 30% uptake in our patient population, again, mostly driven by our nurse navigator who's moving patients into that program. And then we're currently evaluating the uptake of MRI in this patient population. So clearly, we're now able to describe our entire patient population, which we certainly were not able to do so before, and really starting to think of ourselves as a population management program and how we can integrate these diagnostics into that population management to mitigate patients' risk and to identify breast cancers early and evaluate these new technologies that, in this period of time, we implemented tomosynthesis, there's contrast-enhanced mammography. New technologies are coming out all the time, and being able to put those into the context of our cancer detection rate for our high-risk population. So I'm going to end there to say that there's still a lot of work to be done, but these reference implementations we can learn a great deal from.